Okay, to begin, I would do a quick presentation on the roles and responsibilities of a code, but we're going to skip that part today, and we're just going to, I'm going to slow motion walk you through what it would look like if you were initiating a code. So of course we have our patient here. I didn't ask you how to the CPR bed, or the CPR thing.
Do it.
Oh, okay. So pretend like I did that. So of course you're gonna assess your patient, feel for a pulse, no more than 10 seconds, hit your code button, and then if you are by yourself, which hopefully in your area you will not be, but you are gonna start compressions. And whoever initiates the code is gonna be the team leader, regardless of your role, until someone comes to relieve you. So your only responsibility is to worry about compressions, high quality, uninterrupted compressions. As soon as people start arriving, as the team leader, you're going to start assigning them roles. You may or may not know who is responding or what their role is. So people who are responding, it's helpful if you tell them, I've got meds, I've got airway, so that they don't have to guess who you are. But whoever initiates the code is the team leader until someone else relieves them. If they assign you a role that you're not comfortable with, or that you don't know, or that's out of scope, just say, I can't do that, but I can do this. The other thing is whoever started compressions, we want to keep that fresh compressor on the chest. If we're doing perfect CPR, we're only going to perfuse at roughly 30%. So how long have you been doing compressions? Maybe the first person who responds brings the code cart, and you, maybe, I don't know, they were helping another patient. So you were doing compressions for a minute and now you're tired. So the first thing you need to say is, I need you to take over compressions. I'll get everything off the cart. Or hopefully they're here right away and you can have them, you continue doing compressions and they will get everything off the cart. So I've been doing compressions. My friend arrived rather quickly, brought the code cart, so I'm gonna continue doing compressions while you grab the monitor and the backboard and pads off the cart.
And we would probably put this on the side table here. That's since he has a bilateral lower amputation.
We have plenty of room. So once she has the backboard and pads ready, if possible, she's gonna go to the opposite side of the bed so that it's a little bit easier. She's gonna get the pads and the backboard ready, and when she has them ready, she's gonna communicate with me that the pads and backboard are ready and that we are gonna turn toward me.
Check pads.
That's just because I don't have the simulator on yet. So once she has them ready, we're gonna count to 3 and turn toward me and apply the pad and the backboard at the same time. That's okay, I'm doing high quality uninterrupted CPR.
Wait, should she take the back off?
Yes.
Oh.
Because otherwise it will analyze it.
X-ray.
All right, ready? One,
Wait,
two,
are we doing the front or the back? Sorry.
either one.
Okay.
1, 2, 3.
Yeah, you choose. The backboard. It's okay.
Ready? 1, 2, 3. Now I'm gonna go back to CPR. I'm doing CPR, but because these are training pads, I have to hook up my simulator. So once we have the monitor on and the pads and backboard on, we want to analyze our rhythm. So we need to stop doing compressions and analyze the rhythm. Shockable, yes or no? Shockable, yes. So we are going to hit charge, do compressions while it's charging. Whoever's on the monitor is going to say clear, all clear, everybody clear.
Clear.
Visualize that we're clear and hit shock, and then we're gonna go right back to the chest. So On our monitor, all of this purple is going to be our feedback device. So right now, it's doing a timer for how long I've been off the chest. Next, you'll see the bar for release. If that bar is completely full, that means that our feedback is accurate. So we want to do complete recoil of the chest to allow the heart to fill, and so that our feedback device kind of gets back to baseline. So if that bar is full, our feedback is accurate. If our bar is not full, we want to lift completely off the chest. Next is our diamond. We want that to be completely full. That means we're perfusing our patient. So when I start CPR, you'll see this timer change to depth and rate. And then watch that diamond and tell me when that diamond is completely full. Is it full?
It's full.
Yep.
Okay. So now I'm gonna stop for less than 10 seconds. Tell me when it's full.
Now.
See how much quicker? That is the importance of less than 10 seconds off the chest. You get that perfusion back a lot faster. If you are going too slow, you will hear a metronome kick in, telling with the beat for you to go faster. And if you're not pushing deep enough, it will tell you to push harder, and then it will also tell you if you're doing good compressions. So we hooked up to the monitor. How did we know what to turn it to? We have red, green, or gray. What color do we turn it to? Red is dead. So green is good. Green means you have a heartbeat. We just need to go faster. Monitor, all we can do is monitor. So we'd never want to use that unless we're using this as an X3 or just a regular monitor. Red is dead. Red has stopped. Your heart has stopped. Your patient is dead. Red, dead. Turn it to red. That's what we can defibrillate if needed. So you want to turn it to red. Next, we analyzed our rhythm once we got them hooked up to the monitor. You'll notice this button says analyze. We don't want to push that button unless we are not ACLS certified or we don't know our rhythms. That will turn it into an AED, and you will just do what it says when it says. Why don't we want to leave it in AED mode? Any guesses? Your AED is only going to shock approximately 10% of your shockable rhythms. Think about any patient that you've had on a monitor. It rang out asystole, but you were talking to them, or apneic, and they were breathing. Do you trust yourself or do you trust the monitor? You trust yourself. So you want to analyze the rhythm. So ask yourself, shockable, yes or no. That's all you need to know, and then hit charge. And then when it's charged, you'll shock. So we put the pads and backboard on. We hooked them up to the monitor. We delivered a shock. When our code team arrives or help, we're gonna worry about the airway. So if they don't have an advanced airway, you're just gonna get your ambu bag, or if they have an advanced airway. Do you want to open this?
We could use the practice one.
Oh.
Keep that one nice.
So when you grab your ambu bag, you want to grab the ambu bag and the mask out of there. You're going to hook this up to your wall oxygen and then just turn it completely up. Make sure this is out, and when you have the oxygen on, you want to make sure this bag is completely full. Put your mask on here, and then you can bag your patient. So one of the things, if you have limited people, what's our compression to breath ratio if we don't have an advanced airway? 30-2. So who's done RQI? And you're able to give those breaths completely by yourself with no issues.
Yeah.
You probably can. My hands are not big enough.
Oh.
So whoever is doing airway,
Gentle hint.
you just want to focus on that seal, opening that airway. Whoever's doing compressions, they have to stop to give the 2 breaths anyway, right? So whoever's doing compressions is going to compress 28, 29, 30, breath, breath, and then go right back to compressions. Whoever's on airway is just going to hold the mask. So you have 2-person bagging technique. Right now. Okay. So the other thing is capnography. So all of our Zols have capnography cord on them. The cord is reusable, and then she is getting the disposable piece that you need out of the airway box. Now, respiratory does request that they're the ones who gets stuff out, just because they have everything where they know where it is. But this is the piece that you're looking for. It's a clear plastic piece. You want me to open it?
Kelly, we can get another of these, right? The title.
Yep. So you just need this piece. It's just gonna slip in here, and then it'll go one way on your, I always put it on wrong, but it'll only fit one way, right between your mask and your ambu bag. And then all of this yellow up here, yours says disabled
Well,
for some reason. Did it work?
still says disabled.
Can you unplug it and plug it back in?
You can edit.
Good to know. Sorry, doesn't work. Maybe we need a new cable.
It might be a setting on your Zoll.
Disabled. Yeah, that's true. It could be.
That's okay.
Let's just
We'll
pretend.
pretend it's working.
I brought my
Your lovely education.
one if you want me
Oh,
to see what it
that
looks
is
like.
why she brought hers.
Okay.
It'll just have, over here will be the yellow part.
I was like,
And while she gets mine set up, it'll have, it'll be yellow, and that is all your capnography. So it tells you what your CO2 is. So what is your normal CO2? 35 to 45. So if we are doing 100% perfect CPR, and we're only perfusing our patient at roughly 30%, what is our goal while doing compressions? Normal is 35 to 45. Roughly 30%. What's our goal? Throw a number out there. Close. 10 or above. We want 10 or above. So if we're doing compressions, we want to see that CO2 to read 10 or above. So that means that we're perfusing our patient. It's just an extra piece of data for us. So if we have 10 and suddenly we see it jump up to 30, what's that tell us?
Maybe they're
Possibly ROSC. Are you
Yeah.
going to stop doing compressions? Yep. Not unless your patient's pushing you off. So you're going to keep going, but at the next pulse and rhythm check, you're probably going to have a pulse. You probably have ROSC. So there's your CO2 right there. Our mannequin obviously doesn't have any CO2 because it's a mannequin, so you're not going to get a number, but that's where you would look for. So just to recap, I called the code. My good friend came with the crash cart. We got the pads and backboard on at the same time. We hooked the monitor up, we analyzed, it was shockable. So we shocked, and then we went back to CPR. So once we resume CPR, you're gonna ask 3 questions. How's my airway breathing? Are you having any difficulty? No.
Nope.
How's my circulation? We know what our circulation is. What med is next? What is next in my algorithm? So what medication would we get first? Epi. Do we give it now or later?
That's a recycle.
after another cycle. So because it was a shockable rhythm, we want 2 full minutes of CPR. So we're gonna wait until the next pulse and rhythm check. We're gonna see if it's a shockable rhythm, deliver a shock, and then go back to CPR. How's my airway breathing? How's my circulation? What med are we ready for? We have epi ready, we're gonna give it. What med is next? 300 of amiodarone. So why do we take the time to ask airway breathing, circulation, what med is next?
So the meds can circulate.
So the meds can circulate, because if you push a med and you're not doing CPR, what's happening to that medication?
It's sitting there.
It's just sitting there. The other reason is, how many of you have been to a code? Is it super quiet and you can hear everything that's happening? What if my airway person can't get a breath in and they've been trying to tell us, but it's so loud that we don't know? By taking that time, we're addressing our ABCs, airway breathing, circulation, what's next in my algorithm. That takes approximately 10 to 15 seconds. We have circulation, now we can give a medication and get the next one ready. So our code drugs are epi, amiodarone, and what else?
Are you talking BTAC?
Mm-hmm. Lidocaine. So you never want to give 2 code drugs in the same pulse and rhythm check, and you never want to give the same code drug twice in a row. So how often can you give your epi? 3 to 5 minutes. How many doses of amiodarone can you give? 2. We said first dose is 300. What's our second? 150. How do we remember? If we can't remember dose, which one are we going to go with?
Big.
Go big or go home. Your patient's not getting deader, right? So you're going to throw everything at them. Go the biggest dose. So if we are giving a medication at every pulse and rhythm check, how often are we giving our epi? So we're going to give epi, amio, epi, amio, epi. What'd you say?
4 minutes.
Every 4 minutes, right in the middle of your 3 to 5, right? 3 to 5 is what we want to aim for. So if your physician, anesthesia, whoever's running the code wants to give it every 3 minutes, it's not wrong. But how much easier is it to keep track of if you're doing it with every pulse check? It's a lot easier. So, sorry, epi, amio, epi, amio, epi, then lido. You could do lidocaine, but by that point, how long have we been doing CPR?
You ran through a train med.
Yeah, so why wouldn't we go for lidocaine first? It's not wrong. We can do either lidocaine or amio.
So there might be an
But
underlying
what's
issue.
your dose of lidocaine? Does anyone know? Would anyone like to check our algorithm and find out?
Is that why we're not giving it? Because people don't know the dose? Or is it because it's a crazy dose?
Is it weight based?
Kind of both. It's
Okay.
weight based. So
So then you have to do math.
math. Who wants to do math during a code?
I don't want to do math ever.
Not me. So that's typically why we're gonna go to amio first, because it's a fixed dose.
1 to 1.5 milligrams per kilogram. No one wants to do
So
math.
if you have a bigger patient, you have to give an adequate dose for it to be effective. So if you don't give enough, it's not going to be effective. And math. Who's gonna do math during a code? Not me.
So then just do epi again.
Yeah, but you would just skip
Every-
other.
Yeah.
Yeah. But also, how long have we been coding? How long does it take for an anoxic brain injury?
Probably not
10
long.
minutes?
Less than 5 minutes. So if we've gotten to that point, what are we actually getting back? So hopefully we're having conversations with family. Now, those are our code drugs, but after we take the 10 to 15 seconds to talk about airway breathing, circulation, what's next in my algorithm, we have approximately 1 minute and 45 seconds till the next pulse and rhythm check. What are we going to talk about? H's and T's, reversals. What happened to my patient? Why are they coding? If we don't figure out what caused the code, we're either not going to get our patient back, or if we get them back, they're just going to code again. So we really need to find out what's going on with them. So H's and T's. Our recorder's going to let us know when we're approaching a pulse and rhythm check, so we can wrap up our conversation, analyze our rhythm, shock if needed, and then airway, breathing, circulation, what's next in my algorithm, give the medication that is due, and then pick up the conversation where we left off. I had something and I lost my train of thought, so.
Can't imagine why.
Right, this is why we're recording, right?
H's and T's.
H's and T's.
We've talked about like go ahead. Get your train of thought.
Yes. So we hook them up, and why do we interrupt compressions? To put our pads and backboard on and to analyze our rhythm. What is your goal during a code? Efficiency. We want to shock them out of whatever rhythm they're in. That's why we want to see what's happening and shock as soon as possible. The sooner we shock, the more effective it will be. Our second line is our medication. So if they're either not in a shockable rhythm or the shock wasn't effective, we want to get their heart to that shocking state. So that's when we bring in the medications. So because it's a shockable rhythm, we're going to shock and then do 2 full minutes of CPR. What if we put the monitor on and it was not a shockable rhythm? We had asystole or PEA. What are we going to do? Push epi. Are we going to wait for that 2 minutes of CPR? No, because they weren't in a shockable rhythm, so we're going to give that med right away. We're not going to wait for that 2 minutes. That's the difference between your shockable and non-shockable. Let's see. The other thing I like to remind people is that your coding patient is literally the easiest patient you will ever take care of. Why do I say that? No other patient comes with written instructions, step-by-step instructions, that is your algorithm. So all you have to do is find your algorithm and follow your instructions. And your patient isn't gonna get better, right? You can't make it worse.